Thank you, Dr. Moran, and really thank you for the invitation to Dr. Sharma and Dr. Kinney and Dr. Moran for this. This is great to be here. And this is an extra special pleasure because I'm getting to debate with an old attending of mine. So anyway, I have no, So I have no disclosures for this talk. And this slide really has all of the evidence that exists in the randomized cohort of patients. I know that when you look at this, when you know about the PROTECT-2 trial, that if you look at the 90-day endpoint, and particularly for the per protocol analysis, there is a benefit and it does reach statistical significance. But if you look at the intention to treat use, and we have to remember that this was not a positive trial. So if you're one of those people that are doing mechanical circulatory support for all of your high-risk PCI, then what you're doing is you're listening to this guy, who is our esteemed interventional cardiologist, trialist, who says that this is probably a really good idea. But here's my question. Greg, where's the data? So what do the guidelines tell us? Well, what the guidelines say is that the routine use of hemodynamic support for device for complex PCI has not been shown to reduce cardiovascular events, and for that reason, they give it a 2B indication. And they're saying in selected high-risk patients, elective insertion of appropriate hemodynamic support as an adjunct to PCI may be reasonable to prevent hemodynamic compromise, but that you really have to caution with patients that have severe peripheral vascular disease, as we just heard recently about why we didn't use it in the last case, or if they have aortic valve disease. So the guidelines looked at two major studies, the PROTECT-2 trial, which I just mentioned. The PROTECT-2 trial really compared the outcomes of intra-aortic balloon pump versus Impala in a population of high-risk patients who underwent non-emergent PCI. And what they found is that there was not a difference, that the patients with the Impala did not result in a superior outcome in the primary endpoint at 30 days. In fact, this trial, they suspended it because of the fact that the interim analysis showed that there was no difference in MACE. Now, I did mention the 90-day, there was some separation, but that was really for the per protocol analysis. The BCIS-1 trial was another trial that randomized 301 patients with severe LV dysfunction and extensive coronary artery disease that underwent elective intra-aortic balloon pump insertion before PCI. And so the study did not, again, show any difference in MACE at hospital discharge, and therefore did not support the use of routine intra-aortic balloon pump insertion before every high-risk PCI. So these were the two studies that were looked at. Certainly, you could argue that in PROTECT-2, this was older data, older trial. We have better equipment now. We have better Impella device. So you could argue against some of these trials. What we do know now is that mechanical circulatory support has been used in high-risk PCI despite a lack of robust randomized evidence to support its use. What we also know is what Dr. LaSala said earlier today, which is that protected PCI is not for everyone, right? Why? Because the patients, the CHIP patients, are not all the same. You have to look at patient-related criteria. You have to look at what the anatomical lesion looks like. You have to see what the hemodynamic status is. And even when you take the patient factors, look at the anatomy as well as the hemodynamic status, then in that you have to find that subset of patients that are definitely CHIP that would actually benefit from the use of mechanical circulatory device. And remember, protected PCI is not risk-free, right? So this is a study that showed that you have risk of blood transfusion. You can have, acute kidney injury that can even require dialysis. Vascular complications is right up there, even a history of stroke and mortality. So we know both intra-aortic balloon pump was associated with bleeding, vascular and non-vascular complications, but an Impella is larger bore, again, increase in bleeding and vascular complications. If you use it for a longer-term use, there's always that elevated risk of hemolysis that can contribute to the acute kidney injury. You can also have device migration that can result in an injury to the aortic valve or the mitral valve, sometimes even necessitating surgical repair. So you would ask, is it feasible or is it safe to do a high-risk PCI without mechanical circulatory support? Well, you just saw examples today of really high-risk patients that were done without it. But in this particular study that was published, this was a single-center retrospective analysis of patients meeting contemporary high-risk PCI criteria. So they looked at about 1,600 patients, and what they did was they excluded patients with acute coronary syndrome and cardiogenic shock, but they certainly included patients with stable coronary disease, and what they found was that the procedural success was 98%, and that the rescue mechanical circulatory utilization was 0.8%. And so they concluded that high-risk PCI is feasible, safe in a vast majority of patients. And you would all argue that given the cases that we've seen today, this is a true statement, that it is possible to do high-risk PCI, and not every patient needs MCS. So you have to, in contemporary use, look at the high-risk PCI features, decide which CHIP patient is the one that potentially requires it, have a heart team approach, and then pick the patients that may benefit from protected PCI. So I would argue there is no one-size-fits-all approach. And remember, there is no perfect device, and we saw that today in terms of the disagreement with what device you use, but also what device to use for mechanical support, even though we use Impella predominantly. And if you look at everything, the sum of current evidence in favor of MCS includes limited randomized data, small sample sizes, primarily surrogate outcomes, no comparison with medical or surgical therapy, and typically short-term follow-up. So we have to keep this in mind. And so my question is there a middle ground? You don't have to be a therapeutic nihilism versus irrational exuberance. So while most contemporary PCI by far does not necessitate any consideration of hemodynamic support, and more high quality and randomized evidence is really needed at this point, there's likely some middle ground between therapeutic nihilism and irrational exuberance, right, on both sides of the argument. So I would say in the end, for the time being, for complex decision-making, whether to use prophylactic MCS should be approached in a thoughtful and considered in a multidisciplinary, team-based, patient-centered, evidence-based manner. So, Dr. Stone, we eagerly await the results of PROTECT 4, which I know that you're the PI of. 1,250 patients planned a prospective randomized control trial looking at left main multivessel coronary disease and EF less than 40%. These patients were prohibitive risk of CABG, and they're going to be looking at the composite of death, stroke, non-procedural MI, repeat revascularization at 90 days, as well as the BCS3, which is also in progress. So we'll look forward to the results of that. And so I'm going to end with saying, to know that we know what we know, and to know that we do not know what we do not know, that is true knowledge. So thank you very much.